Welcome to this video entitled Viral Hepatitis. Next we will look at a definition. Viral hepatitis refers to the clinically important hepatotropic viruses responsible for hepatitis A, abbreviated as HAV, hepatitis B, abbreviated as HBV, delta hepatitis, hepatitis C, abbreviated as HCV, and hepatitis E. Let's begin with hepatitis A1. Hepatitis or infection primarily occurs through transmission by the fecal-oral route, person to person, or by ingestion of contaminated food or water. The incidence of hepatitis A correlates directly with low socioeconomic status, poor sanitary conditions, and overcrowding. Rates of hepatitis or infection have increased among international travelers, injection drug users, and men who have sex with men. 2. Hepatitis or infection usually produces a self-limited disease and acute viral infection with a low case fatality rate, and confers lifelong immunity. 3. The disease exhibits 3 phases. Incubation, averaging 28 days, with a range of 15 to 50 days, acute hepatitis, generally lasting 2 months, and convalescence. Most patients have full clinical and biochemical recovery within 12 weeks. Nearly all individuals will have clinical resolution within 6 months of the infection. Hepatitis A does not lead to chronic infections. 4. The clinical presentation of hepatitis or infection is given in Table 25.1. 5. The diagnosis of acute hepatitis or infection is based on clinical criteria of acute onset of fatigue, abdominal pain, loss of appetite, intermittent nausea and vomiting, jaundice or elevated serum aminotransferase levels, and serologic testing for immunoglobulin, IgG, anti-hepatitis A. We will now look at the treatment of hepatitis or infection. No specific treatment options exist for hepatitis A. Management of hepatitis A infection is primarily supportive. Steroid use is not recommended. We will now discuss the prevention of hepatitis A virus. 1. The spread of hepatitis A virus can be best controlled by avoiding exposure. The most important measures to avoid exposure include good hand washing techniques and good personal hygiene practices. 2. The current vaccination strategy in the United States includes vaccinating all children at 1 year of age. Groups who should receive hepatitis A virus vaccine are shown in Table 25.2. 3. 2 inactivated virus vaccines are currently licensed in the United States, Havrix and Vactor. Approved dosing recommendations are shown in Table 25.3. Seroconversion rates greater than 94% are achieved with the first dose. 3. Ig is used when pre- or post-exposure prophylaxis against hepatitis A virus infection is needed. It is most effective if given during the incubation phase of infection. A single dose of Ig of 0.02 ml per kilogram intramuscularly is recommended for travelers to high-risk areas if travel is for less than 3 months. For lengthy stays, a single dose of 0.06 ml per kilogram is used. 4. For people recently exposed to hepatitis A virus and not previously vaccinated, Ig is indicated for those in close contact with a hepatitis A virus-infected person, all staff and attendees of daycare centers when hepatitis A virus is documented, if involved in a common source exposure, such as a foodborne outbreak, classroom contacts of an index case patient, and schools, hospitals, and work settings where close personal contact occurred with the case patient. 5. Common vaccine side effects include soreness and warmth at the injection site, headache, malaise, and pain. Pause the video and carefully scrutinize Table 25(1) summarizing clinical presentation of acute hepatitis A before advancing to the next slide. Pause the video and carefully scrutinize Table 25(2) summarizing recommendations for hepatitis A vaccination before advancing to the next slide. Pause the video and carefully scrutinize Table 25(3) summarizing recommended dosing of Havrix and Vactor before advancing to the next slide. Let's now discuss hepatitis B1. Hepatitis B virus is a leading cause of chronic hepatitis, cirrhosis, and hepatocellular carcinoma. 2. Transmission of hepatitis B virus occurs sexually, parenterally, and perinatally. In the United States, transmission occurs predominantly through sexual contact or injection drug use. International travel is also an important risk factor. 3. Approximately 20% of patients with chronic hepatitis B virus infection develop complications of decompensated cirrhosis, including hepatic insufficiency and portal hypertension. Hepatitis B virus is a risk factor for development of hepatocellular carcinoma. 4. There are 3 phases of hepatitis B virus infection. The incubation period for hepatitis B virus is 4 to 10 weeks, during which patients are highly infective. This is followed by a symptomatic phase with intermittent flares of hepatitis and marked increases in aminotransferase serum levels. The final phase is seroconversion to anti-hepatitis B core antigen, abbreviated as anti-HBsAg. Patients who continue to have detectable hepatitis B surface antigen, HBsAg, and anti-hepatitis B core antigen and a high serum titer of hepatitis B virus DNA for more than 6 months have chronic hepatitis B virus. 5. The interpretation of serologic markers for hepatitis B virus is given in Table 25(4). 6. Clinical manifestations of acute hepatitis B virus infection are age-dependent. Infants infected with hepatitis B virus are generally asymptomatic, while about 85% to 95% of children aged 1 to 5 years are asymptomatic. 7. The clinical presentation of chronic hepatitis B virus is given in Table 25(5). Pause the video and carefully scrutinize Table 25(4) summarizing the interpretation of serologic tests in hepatitis B virus before advancing to the next slide. We will now discuss the prevention of hepatitis B virus infection. 1. Prophylaxis of hepatitis B virus can be achieved by vaccination or by passive immunity in post-exposure cases with hepatitis B immunoglobulin. 2. 2 products are available for prevention of hepatitis B infection. Hepatitis B vaccine, which provides active immunity, and hepatitis B immune globulin, abbreviated as HBIG, which provides temporary passive immunity. 3. The goals of immunization against viral hepatitis include prevention of the short-term viremia that can lead to transmission of infection, clinical disease, and chronic hepatitis B virus infection. 4. Persons who should receive hepatitis B virus vaccine are listed in Table 25(6). 5. Side effects of the vaccines are soreness at the injection site, headache, fatigue, irritability, and fever. Let's now briefly discuss hepatitis B immune globulin. 1. Hepatitis B immune globulin, abbreviated as HBIG, is used only for post-exposure prophylaxis for hepatitis B virus for perinatal exposure of infants of hepatitis B virus carrier mothers, sexual exposure to hepatitis B surface antigen positive persons, percutaneous or permucosal exposure to hepatitis B surface antigen positive blood, and exposure of an infant to a caregiver who has acute hepatitis B2. The recommended dose is 0.06 ml per kilogram administered intramuscularly. Pause the video and carefully scrutinize Table 25.5 summarizing the clinical presentation of chronic hepatitis B before advancing to the next slide. Pause the video and carefully scrutinize Table 25.6 summarizing recommendations for hepatitis B virus vaccination before advancing to the next slide. We will now discuss the treatment of hepatitis B virus infection. 1. The key goals of therapy are to increase the likelihood of immunoclearance of the virus, prevent disease progression to cirrhosis or hepatocellular carcinoma, and to minimize further liver injury. Successful therapy is associated with loss of anti-hepatitis B core antigen status and seroconversion to anti-hepatitis B core antigen. 2. No specific therapy is available for the management of acute hepatitis B virus infection. Some patients with chronic hepatitis B virus infection should be treated. A suggested treatment algorithm for chronic hepatitis B virus is as shown for patients without, as shown in Figure 25.1, and with cirrhosis, as shown in Figure 25.2. 3. All chronic hepatitis B virus infection patients should avoid alcohol and be immunized against hepatitis A virus. 4. Drug therapy is used to suppress viral replication by immune-mediating or antiviral effects. Interferon alpha-2b, abbreviated as IFN alpha-2b, lamivudine, telbivudine, adifovir entecavir, and pegylated IFN alpha-2a, abbreviated as PEG-IFN, are approved in the United States for first-line treatment of chronic hepatitis B virus. 5. Several factors correlate with improved response to interferon therapy, including increased alanine transaminases and hepatitis B virus DNA levels, high histologic activity score at biopsy, and being non-Asian. Treatment for a minimum of 12 months is associated with greater sustained virologic response rates than treatment for 4 to 6 months. Conventional interferon therapy has been virtually replaced with pegylated interferon, because of the ease of administration, once-weekly injections, fewer side effects, and improved efficacy. 6. Lamivudine, dosed at 100 mg daily given orally, may be used alone or in combination with PEG-IFN for chronic HBV. Pause the video and carefully scrutinize Figure 25.1 illustrating a suggested treatment algorithm for patients with chronic hepatitis B virus infection before advancing to the next slide. Next we will discuss hepatitis C1. Hepatitis C virus is the most common blood-borne pathogen. Screening for hepatitis C virus infection is recommended in selected groups who are at high risk for infection, as shown in Table 25.7. 2. Hepatitis C virus is most often acquired through IV drug use, sexual contact, hemodialysis, or household, occupational, or perinatal exposure. 3. In the vast majority of patients, up to 85%, acute hepatitis C virus infection leads to chronic infection defined by persistently detectable hepatitis C virus RNA for 6 months or more. 4. Patients with acute hepatitis C virus are often asymptomatic and undiagnosed. 1/3 of adults will experience some mild and nonspecific symptoms, including fatigue, anorexia, weakness, jaundice, abdominal pain, or dark urine. 5. The most common symptom of chronic hepatitis C virus infection is persistent fatigue. An estimated 20% of patients with chronic hepatitis C virus infection will develop cirrhosis, and half of those patients will progress to decompensated cirrhosis or hepatocellular carcinoma. 6. The diagnosis of hepatitis C virus infection is confirmed with a reactive enzyme immunoassay for anti-hepatitis C virus. Serum transaminase values are elevated within 4 to 12 weeks after exposure. Pause the video and carefully scrutinize Figure 25.2, illustrating suggested treatment algorithm for patients with chronic hepatitis B virus infection before advancing to the next slide. Pause the video and carefully scrutinize Table 25.7 summarizing recommendations for hepatitis C virus screening before advancing to the next slide. Pause the video and carefully scrutinize Table 25.8 summarizing recommended hepatitis C virus treatment dosing before advancing to the next slide. Pause the video and carefully scrutinize Table 25.9 summarizing pegylated interferon comparison before advancing to the next slide. Pause the video and carefully scrutinize Table 25.10 summarizing common side effects associated with PEG interferon therapy, experienced by more than 20% of patients, before advancing to the next slide. Pause the video and carefully scrutinize Figure 25.3, illustrating suggested response-optimized chronic hepatitis C virus infection treatment regimens before advancing to the next slide. Next we will discuss the treatment of hepatitis C virus infection. 1. The goal of treating hepatitis C virus is to eradicate hepatitis C virus infection, which prevents the development of chronic hepatitis C virus infection and sequelae. 2. Treatment for hepatitis C virus infection is necessary because a high percentage of acutely infected patients develop chronic infections. Treatment is indicated in patients previously untreated who have chronic hepatitis C virus, circulating hepatitis C virus RNA, increased alanine transaminases levels, evidence on biopsy of moderate to severe hepatic grade and stage, and compensated liver disease. 3. Contraindications to treatment include autoimmune hepatitis, decompensated liver disease, women who are pregnant or patients whose female partners are pregnant, hemoglobinopathies, creatinine clearance less than 50 ml per minute, hemodialysis, or ischemic cardiovascular or cerebrovascular disease. 4. Treatment response is best in patients with hepatitis C virus genotype 1 and those who take at least 80% of their medications for at least 80% of the treatment time. 5. All patients with chronic hepatitis C virus infection should be vaccinated for hepatitis A and B. Patients should be advised to maintain good overall health, stop smoking, and avoid alcohol and illicit drugs. 6. The current standard of treatment for chronic hepatitis C virus infection is a combination of once-weekly pegylated interferon and a daily oral dose of ribavirin. Sustained virologic response rates are 54% to 56%. Therapy is optimized based on genotype, patient weight, and response to therapy. Recommended treatment regimens for hepatitis C virus infection are given in Table 25.8 and Figure 25.3. 7. Two pegylated interferons are available, Pegasys and PEG-intron, shown in Table 25.9. It is unclear which is superior. 8. Common side effects of PEG-interferon are given in Table 25.10. Common side effects of ribavirin are fatigue, flu-like symptoms, neutropenia, thrombocytopenia, and anemia. Finally, Regarding the prevention of hepatitis C virus infection, no hepatitis C virus vaccine is currently available. Thank you.